Welcome to the recorded version of Caring for Someone with Dementia, part of the Family Caregiver Support webinar series brought to you by the American Society on Aging and a generous sponsorship from Home Instead Senior Care.
Okay, our presenters today are going to be Lakeland Hogan and Doug Pace. Lakeland Hogan is a gerontologist and caregiver advocate for Home Instead Senior Care. Lakeland works to educate professionals, families, and communities on issues older adults face. Lakeland is a doctoral candidate at the University of Nebraska-Omaha, where she is studying social gerontology. She has a Master of Arts in Social Gerontology and Masters in Business Administration from UNO. Lakeland has professional experience in the private and public sectors of senior care services. She has worked on special projects for UNO's Department of Gerontology and the local area agency on aging. Lakeland serves as Vice President of the Board of Directors for the Dreamweaver Foundation and is active in the Alzheimer's Association's Walk to End Alzheimer's. Lakeland has a passion for helping others, especially aging adults and their families. Also joining us today is Doug Pace. Doug is the Director of Mission Partnerships with the Alzheimer's Association. In this role, he provides strategic leadership with government and other organizations to enhance the association's influence in the area of dementia care. Previously, Doug was the Executive Director of the Advancing Excellence in Long-Term Care Collaborative. He is a licensed nursing home administrator who ran a 210-bed multi-level facility, including an SNF, a secured Alzheimer's unit, and assisted living before joining Leading Age Tennessee. And with that, I would like to turn the floor over to Lakeland and Doug. Welcome.
Thank you so much, Steve. Hello, everyone. We're so glad that you have chosen to join us today on an important topic of caring for someone with dementia. This is a topic that I am very passionate about, and many people tend to think that dementia is a normal part of aging, when it is definitely not. However, we are seeing more and more individuals affected by dementia, and in turn, we're seeing more family members and care partners stepping in to provide care and support. In my experience working with these caregivers, their roles can sometimes be challenging, but also can be very rewarding. It can be especially challenging when family members do not necessarily understand Alzheimer's or dementia and the symptoms that might present as a result of the disease. These family members and care partners often turn to us as professionals for resources and support. So again, I'm glad that you're joining us today to learn about caring for someone with dementia. And we're going to be talking more specifically about a person-centered care approach. And I'm excited to have a guest presenter with us, Doug Pace, who will be talking more about person-centered care for someone living with dementia. He's with the Alzheimer's Association, and the Alzheimer's Association really is the leader in this area of care and support and research, and they really recently released some new dementia care practice recommendations that Doug's going to share with us later. But I'm going to get us started today. I will review the objectives here on the first slide. So my hope is that throughout this presentation, we'll cover kind of the basics of dementia. There are different types of dementia, so I want to make sure we're all on the same page. Many of you might have basic knowledge, but we'll just do a quick review. And then I'm going to go into more detail about the symptoms and how to minimize the symptoms. And again, the symptoms can sometimes be challenging for family caregivers and care partners. However, with some strategies and tips, it really can help to understand the symptoms and then again how to minimize them. And then we're going to be talking about that person-centered care approach, which is really important because we need to recognize that the individual living with the disease is still a person and that our approach to care and support for them really should be individualized. And so Doug's going to talk more about that in just a little bit. And then finally, we're going to share some resources with you that you can pass along to those that you work with. So we're going to start again with that quick review of dementia. So dementia is a decline in mental ability that's severe enough to interfere with daily life. And again, many people think that, a mental decline in our cognition is a normal part of aging. And there is a little bit of cognitive decline that might take place, but when it starts to interfere with daily life, that is not a normal part of aging. So we want family members to recognize this. And in a little bit, I'll share some first signs when there might be some cognitive impairment occurring. So if we can educate families on that, we can help them get their loved one to a medical professional when appropriate. When we talk about the term dementia, I like to think of it as an umbrella. So there's different types of dementia that fall underneath that umbrella. And you can see on the graphic here, sometimes I'm a visual learner, so it helps to see it. So there's different types: vascular dementia, Lewy body, Alzheimer's disease, frontal temporal, and people can even have a mix of several types of dementias. And if you take kind of a big, huge look at dementia, there's over 100 different types of dementia. But we do know that Alzheimer's disease is the most common. So for the purpose of today's webinar, we are going to talk a lot about Alzheimer's disease, and so I did want to go over that quickly here with you on the next slide. So again, it is the most common form of dementia. We see 60 to 80% of dementia cases are Alzheimer's disease. We know that the greatest risk factor for this disease is age. However, it is not just a disease of old age. There is a younger onset, or sometimes referred to as early onset Alzheimer's disease, that does affect people younger than age 65. And there are over 5 million Americans living with Alzheimer's disease, and of that number, about 5% fall in that younger onset, meaning that they are under the age of 65. So you might be wondering, how does Alzheimer's develop? And what we're finding in the research is that Alzheimer's develops due to microscopic changes in the brain over time. And oftentimes these changes are starting long before memory loss and the signs and symptoms become noticeable in an individual. So there are research is finding that there's two abnormal structures called plaques and tangles that damage and kill the nerve cells in the brain. So on the screen you can see a picture. It's kind of small in the corner, I apologize, but the smaller photo is a healthy nerve cell, and then the larger photo are nerve cells that are damaged by these plaques and tangles. And I could go into more detail. I could do an entire webinar on just kind of the science behind Alzheimer's disease, but I'll share some links with you later on where you can go and learn more about these plaques and tangles and the research that's coming about in this area. But we do know that Alzheimer's disease is progressive, which means that it worsens over time. And you'll often hear Alzheimer's disease described in various stages. Some people describe it in, 3, 5, or 7 stages. I like to stick to 3 because it's easy to remember. So mild Alzheimer's disease, or sometimes referred to as early stage, is when those symptoms start to become most noticeable. And again, I'll go over some of those early symptoms and warning signs of Alzheimer's disease in just a bit. Then there's the moderate stage of Alzheimer's disease, or the middle stage. And this is where people tend to be in for kind of the majority of the time that they're living with the disease. Some people will be in this moderate stage for just a couple of years, and I've also seen individuals living with dementia for 10, 20 years. So again, that moderate stage tends to be kind of the longest stage. And then the last stage, the late stage, or severe Alzheimer's disease, is when the body starts to shut down and the individual enters that end-of-life stage of Alzheimer's disease. Unfortunately, there is no cure for Alzheimer's and no way to currently stop the progression of the disease. However, there are some treatment options available for the symptoms of Alzheimer's disease. So it's important to discuss that with the medical professional to see if those treatment options are right for the individual. But while there's no cure, researchers across the globe are hard at work to better understand Alzheimer's disease and related dementias, and also to work towards a treatment and a cure. And the Alzheimer's Association does a great job in leading that research effort. So I really quickly wanted to just throw some statistics out there to put a little context to Alzheimer's disease. Actually, September is World Alzheimer's Month. The Alzheimer's Disease International Organization recognizes the month of September as a way to raise awareness and reduce the stigma of Alzheimer's disease. So if you look here in the United States, 5.8 million people are living with the disease. It's the 6th leading cause of death, and family caregivers are providing billions of hours of care, 18.5 billion hours of care, which if you put a dollar amount to that, it's pretty outstanding. It'd be $234 billion worth of care and support that they're providing. And then in Canada, about over 400,000 people living with the disease, and the cost there is about $8.3 billion. And if we look worldwide, more than 44 million people are living with dementia, and every 3 seconds, someone in the world has a new diagnosis of Alzheimer's disease or another type of dementia. So it is becoming very prevalent. And we see family members stepping up as the first people to generally provide care and support. So this is a family caregiver support webinar series. And so I think it's really important to recognize that caring for someone living with dementia can impact the individual and can impact their stress level. But the great thing about you joining this webinar today is that hopefully you'll have some tools and support and resources to pass along to help them on that journey. But we do find that nearly half of dementia caregivers say that providing care can be emotionally stressful. People report physical strain, about 29%, and dementia caregivers are about twice as likely to indicate that they've had worsening health as a result of their caregiving role. And they also tend to become more isolated. And some of the reasons due to that is because they might not be able to leave the house as frequently with their loved one. And because of that, they might be feeling a reduced quality of life. And they might stay at home because of their loved one's mobility issues or the unpredictability of the symptoms that their loved one might be exhibiting. So again, hopefully by the end of today's webinar, you'll take away some tips and resources to pass along to these important family caregivers as they provide care and support to their loved ones living with dementia. But as promised, I wanted to quickly go through the early signs and symptoms of Alzheimer's disease. This is very important for family caregivers to know about and to be able to recognize, because a dementia diagnosis can really go a long way in helping the individual get the resources and the care and support that they really do need as they go through this disease. So some of the early symptoms of Alzheimer's disease, again, it's that memory loss that disrupts daily life. They might start to have difficulty completing familiar tasks, some challenges with problem solving and planning. They might find that they're confused with the time and place. If you've ever seen the movie Still Alice, she has a moment where she's on a jog that she's gone on a million times, but all of a sudden finds herself unfamiliar with her surroundings and is unsure how to get home. That's a very powerful scene in that movie that always has stuck with me. And then they might also have trouble understanding visual images and spatial relations. And then if we look at some of the additional signs and symptoms that might present earlier on in the disease, they might have trouble speaking or writing. They might misplace things and lose the ability to retrace their steps to find those things that they have misplaced. You might also see a decreased or poor judgment. They might start making decisions that they wouldn't typically make. They might also withdraw from work and social activities, especially if they're starting to recognize that they are having some sort of cognitive impairment. And then you might also see changes in their mood or personality. And as the individual progresses through the disease, every person will experience different symptoms, but there are some common symptoms that caregivers often want to know, okay, what can I expect in terms of the symptoms that my loved one might exhibit? So this is a great chart that was taken from a book written by Molly Carpenter, Confidence to Care, and it goes over some of the symptoms that a loved one might experience. And again, it's hard to say if every individual will experience these symptoms. Some might experience more than others, but this graphic shows kind of on a grade, if you can see the color changing there. On the left-hand side are symptoms that might be frustrating to the family caregiver, and then it ranges to those in the darker color on the right-hand side, symptoms that might cause harm to the individuals or those providing care and support. So it's really important to understand these symptoms and what might trigger these symptoms, and then find ways to reduce or minimize, the symptom or redirect the individual. And family caregivers, I like to say, put on their detective hats a lot of the time to try to figure out, is there an underlying factor that might be causing some of these symptoms? This is especially helpful as the individual progresses through the disease because they might lose their ability to verbally communicate their needs, so they might be expressing them in some of these symptoms. So I like to encourage caregivers to put on that detective hat and do a quick check. Are any of these categories of needs or unmet needs able to explain the symptoms? So sometimes you have to think to yourself, okay, is it an emotional need, a social need, a physical need, or something in the environment that is causing the individual to perhaps get upset or become disoriented? I want to give just two quick examples. So for instance, if the individual was pacing back and forth and they're unable to express their need at that time, it might be because they're trying to find something. Maybe it's the restroom. Maybe they're trying to get to a certain room of the house, and perhaps they can't verbally express that, and they're trying to navigate their way. So just directing them to the restroom or directing them to areas that you might think that they're trying to get to could help meet that need that they're trying to express. Another example is if you are out in a public place or at a family gathering and the individual with dementia is getting agitated or a little frustrated, it could be something in the environment. Perhaps there's too many people around, perhaps it's too loud, they're overstimulated. So if this is the case, the family caregiver might want to suggest moving to a quieter space for that individual to maybe be by themselves and have a couple of visitors at a time if it's a family gathering, or perhaps there's a different room of the house that's a little bit quieter where they can spend time still engaging with others, but again, the environment is more inviting for where they're at in the disease process. So those are just two quick examples of how family caregivers can really put on that detective hat. But you might start to notice, as I've been talking, that really Alzheimer's disease impacts everyone differently, and that's where this person-centered care approach becomes so important. So this approach is really becoming the gold standard in Alzheimer's and dementia care, and it has a lot of research behind it, and studies are showing that it can help reduce agitation and aggression in people living with dementia, and other studies have shown that it can even reduce the number of hospitalizations and reduce the need for antipsychotic medication use. So the Alzheimer's Association has come up with an updated dementia care practice recommendation that Doug is going to go over in just a few minutes, where they provide guidelines for how professionals can help create this person-centered care approach in their workplaces, and also this can apply to family caregivers. So the great thing about the person-centered care approach for family caregivers and family care partners is they often have the tools and resources that they need right at their fingertips because they know their loved ones so well. So the person-centered approach really centers around getting to know the person, maximizing their independence, really personalizing the care to meet the individual's needs and preferences, adjusting the approach to reflect that day-to-day need. Some days they might be more alert than others or able to engage more easily one day than they are another. So adjusting that approach and then providing opportunities for ongoing engagement that has meaning and purpose to that individual specifically. So that's just a very high level on the person-centered care approach. Now I'm going to turn it over to Doug, and he's going to go through the new dementia care practice recommendations that has been recently put out by the Alzheimer's Association. So Doug, I'll hand it over to you.
Thank you, Lakeland, and thanks to all of you for being on the call today and all you do in providing care and support to our nation's seniors. So as Lakeland said, I'm going to provide an overview of the Association's Dementia Care Practice recommendations. But before I start, I'm sure all of you know of the Alzheimer's Association, but you may not know that we are the world's leading voluntary health organization dedicated to care, support, and research. And we work on a global, national, and local level through our home office in Chicago, our policy office in DC, and 78 chapters nationwide. And our mission is to eliminate Alzheimer's disease through the advancement of research, to provide care and support for all affected, and to reduce the risk of dementia through the promotion of brain health. And our vision is a world without Alzheimer's. So the association has had an ongoing commitment to quality care. In the early 90s, we published guidelines for dignity, followed by key elements of dementia care. And our most recent recommendations prior to this release were published between 2005 and 2009, with distinct recommendations for nursing homes and assisted living, end-of-life care, and for those working in a home care setting. These new peer-reviewed, evidence-based recommendations were published in a special supplement of the February 2018 issue of the Gerontologist. And so these are 56 recommendations by 27 nationally recognized experts, and they provide the foundation for quality person dementia care. And these recommendations are intended for healthcare professionals working in long-term care and community-based settings such as nursing homes, assisted living, life plan communities, home health, hospice, and home care. So the recommendations are anchored in person-centered care, and the additional topic areas are detection and diagnosis, assessment and care planning, medical management, information, education, and support, ongoing care for activities of daily living and dementia-related behaviors, workforce, supportive and therapeutic environments, and transition and coordination of services. Now, everything I'm going to be talking about today is available and free to download on our website. You can find these recommendations at alz.org/qualitycare. There's a lot of great information for you on our website. Also, we have a facts and figures report that we publish every year that has some great information, and you can find that at alz.org/facts. So the first topic area is person-centered care, and that flows through all of the following topic areas. And this first recommendation is really integral to all of the recommendations, and it's knowing the person. So knowing the person living with dementia means gathering knowledge of the person, both present and past. It means including the individual, family, and friends to understand the person's reality, and including the knowledge gained in the care plan and in ongoing reassessments. And very importantly, it's about sharing that knowledge of the person with all staff. It really doesn't do any good if you go to the trouble of collecting all this information and then that just sits in a folder somewhere. So it's really important that all this information is shared with all the staff. And opportunities for meaningful engagement includes creating a supportive environment, looking beyond just traditional and planned activities, and educating staff on how every interaction can become an activity. So it's really about building and nurturing authentic and caring relationships. It's the kind of caring relationships that's about being present and concentrating on the interaction rather than the task. So it's about doing with rather than doing for, and maintaining a supportive community for the individuals, their families, and also the staff. It's a community that values each person, respects individual preferences, celebrates accomplishments, and provides opportunities for autonomy and shared experiences. And finally, it's about evaluating care practices regularly and making appropriate changes. The only way to know if you're making a difference is to regularly evaluate your practices and your models, study and share findings, and make changes to interactions, programs, and practices as needed. So the next topic area is detection and diagnosis. And we know this is important because this is a big issue. So many people that don't have a diagnosis of Alzheimer's dementia. So in addition to updating and enhancing our previous recommendations in areas that are familiar to the care community, these recommendations break important new ground. And most notably, they offer guidance to community-based and residential care providers on detection and diagnosis and ongoing medical management. And these are areas that are typically reserved for clinicians. But recommendations in these two areas are specifically written for non-physician care providers, and they address what providers can do with these important aspects of holistic, person-centered dementia care. So our recommendations outline approaches, actions dementia care providers can make to complement and enhance the work that clinicians are doing. It's about providing information about brain health and cognitive aging. It's about educating staff about the signs and symptoms of cognitive impairment and developing a process for referral to a qualified professional for a diagnostic evaluation. And using a brief mental status test to detect cognitive impairment, but only if the testing is within the scope of practice of the non-physician provider, and then referring them to a physician for a diagnostic evaluation and to offer additional resources so they can fully understand the diagnosis. The next area is assessment and care planning. So comprehensive person-centered assessments are performed on intake, and the recommendations suggest that they should be done at least every 6 months unless a change occurs in between those times. And use the assessment as an opportunity for information and relationship building. It's important to approach the assessment with a collaborative team approach, including the person living with dementia, their care partners, and the care plan team should include a frontline caregiver. Then, using a documentation and a communication system to make sure that it's shared with all staff for use in planning and evaluating care. Now, as I mentioned earlier, the previous recommendations, we had one set of recommendations that focused on advanced care planning and end of life. But with these new recommendations, you'll see the importance of early and ongoing discussion of what matters, including values, quality of life, and goals that are essential to person-centered care, and that includes palliative care and hospice care throughout all of the recommendations. The next area is another one of the new areas. It's around medical management. And this is where non-physician providers adopt a holistic approach to providing care and support and work to reduce barriers to coordination of medical and non-medical care and support. It's about educating staff about common comorbidities and developing a protocol for when the physician should be contacted, and let the physician know about difficulties that they're encountering managing acute and chronic conditions, whether that's they're serving a person in a home or in a residential care community. Now, increasing evidence suggests that non-pharmacological interventions are effective at managing behavior and psychological symptoms of dementia, and those non-pharmacological interventions should be used first before considering pharmacological treatments. And even though we know that non-pharmacological interventions are preferred, we also know that there are times when pharmacological treatments are warranted for behavior and psychological symptoms. So community care providers must understand the principle for starting and, more importantly, ending pharmacological treatments, and asking the medical provider for regular medication review and having a plan to discuss how to discontinue the medications when it's appropriate. So it's important to have a plan in place should a medical or a social crisis occur, such as an illness, hospitalization, or maybe the death of a caregiver. And again, encourage persons living with dementia and their families to start those end-of-life discussions early. Information, education, and support is the next topic area, and discussing the individual's care values and preferences early in the disease can aid in planning during the middle and late stages, as well as end of life. So by discussing important care-related issues earlier on, the individual with dementia's desires and wishes for their own care will remain an important part of the caregiver's decision-making process as the care situation changes. And as a care provider, it is also important to build culturally sensitive programs that are easily adaptable to special populations, such as minority populations, LGBTQ, or socially disadvantaged populations. So highlighting multicultural issues when training professionals will lead to more effective programs that will embrace the unique needs of all care partners. So we know there's many transitional points through the disease trajectory that have variable effect on the care partners, and progression through the various stages of dementia brings about many transitions, such as changes from in-home care to community-based care. So assuring resources are available during times of transition will be reassuring to individuals living with the disease and their care partners. And here's an area, too, where we know that technology can be a tremendous resource for education, information, and support. And technology can especially be useful for people living alone or people in rural communities. The next two areas focus on ongoing care. And ongoing care is such an important topic that we started out having one article and we separated it into two because of the amount of evidence that's there now. So the first set of recommendations focus on activities of daily living, or ADLs. And support for ADL function must recognize the activity, the person's functional ability, and their cognitive impairment. And not only are dignity, respect, and choice a common theme, but providers must attend to the individualized abilities, the likes and the dislikes of the person with dementia. And now we have additional evidence around dressing, toiling, and eating that's listed in the recommendations. So as Lakeland said, it's important to remember that dementia is a progressive disease, accompanied by the progressive loss and the ability to independently conduct ADLs. So here we know that needs will increase over time. And the evidence now shows us, for instance, that dressing, for example, people living with dementia are more able to dress themselves independently if they're in a safe and comfortable area, provided a selective choice, and just given simple verbal instructions. And with toileting, we now have evidence that shows in general people living with dementia are more able to be continent if, for example, they're monitored for signs of leakage or incontinence. They have regularly scheduled bathroom visits. They have access to a bathroom that's clearly evident, that they avoid caffeine and fluids in the evening, and that they engage in constipation prevention activities. And we also know that one of the most important times of the day is mealtime, and people living with dementia are more likely to eat if, for example, they're offered choice. They dine with others in a quiet home-like environment, they maintain good oral health, and they're offered adaptive foods and utensils, and they're also offered not only nutritionally, but also culturally appropriate foods. So the next area of care of ongoing care is listed as BPSD, or Behavioral and Psychosocial Symptoms of Dementia. So since we released the recommendations, we have changed some of our language, and here's an example. So instead of using the term BPSD, we're now moving towards a language of more non-medical terminology, and we're now moving that to dementia-related behaviors. So it's important to identify situations where the social or the physical environment triggers a behavioral response, produces stress, or evokes a behavior that expresses an unmet need. So as I discussed earlier, it's important to implement non-pharmacological practices that are person-centered, evidence-based, and feasible in the care setting where the person is living. So antipsychotic and other psychotic medications are generally not indicated to alleviate dementia-related behaviors, and so non-pharmacological practices should be the first-line approach. And different practices require a different amount of investment in terms of training and implementation, equipment and capital resources, but many are feasible in both residential and home care settings. And protocols of administration assure that there's a guideline for care providers as they try to eliminate dementia-related behaviors, and these protocols will evolve over time. Again, that's why it's necessary to routinely assess the effectiveness of a practice, and if necessary, adapt it or implement other evidence-based practices. So this article in the supplement identified three overarching categories for evidence-based non-pharmacological approaches. But while the evidence varies, aromatherapy, massage therapy, multi-sensory stimulation, and bright light therapy can be effective approaches to reduce episodes of dementia-related behaviors. And psychosocial practices such as validation therapy, reminiscence therapy, music therapy, pet therapy, and meaningful activities can also have positive effects on a wide range of dementia-related behaviors. And again, this is where technology is really making strides. For instance, there's now robotic pet therapy dogs that are showing positive results with some people with dementia. And music therapy programs like Music and Memory have also shown to be very effective. And again, while the evidence is small, but there's growing evidence around structured care protocols that can make a big difference in the quality of life for someone with dementia. So anticipated resistance to daily mouth care is one of the reasons that oral hygiene tends to be neglected, especially in residential care settings. So using mouth care protocol that include person-centered strategies for approaching and communicating, along with technical skills, can really help reduce the threat and thereby minimize resistive behaviors. And from the current evidence, there's little investment that's required to implement structured protocols to prevent or minimize dementia-related behaviors during mouth care. And findings suggest that care providers who've been trained to use a mouth care protocol feel much more able to effectively address behavior responses during care. And bathing is another area that's a personal tearcast that's associated with the frequency of behavioral expressions of distress. And as with mouth care, distress with bathing may just simply signify a fear response that may be potentially alleviated by implementing person-centered strategies and skills. So the next area is workforce. And we know this is one of the most important components of delivering high-quality dementia care. It's important that all staff know the person living with dementia as an individual. So that means procedures must be established that collects information on choices, preferences, and life history, and then again a mechanism for sharing that for all staff. And interdepartmental and interdisciplinary collaboration is crucial, as well as making sure that not only is this information shared on all staffs, but that training is provided on all staffs. A person-centered delivery system is not possible also without a vision-driven leadership team. So this is a leadership team that believes in complete system transformation. Leadership that shows that a well-trained, informed, and empowered staff who feel valued, recognized, and involved in the decision-making is the foundation of person-centered care. And there's many ways that staff can get to know a person, such as consistent assignment and involving residents, staff, and families to cultivate successful relationships. And again, as with all the areas, evaluation is key. So leadership must encourage a culture that all staff welcome, serve, and respond. So there's a few basic workforce principles that are listed in the supplement that are important for quality dementia care. Staffing levels should be adequate, not only just during the daytime, but at nighttime as well. Of course, staff should be sufficiently trained in all aspects of care, including dementia care. We know that there's a big issue with high turnover, and a lot of times if people are put into a situation of caring for people with dementia, and if they're not trained properly, then more than likely they're not going to be a long-term employee, or they're not going to provide good care, or they're going to leave. We also know that staff should be adequately compensated for their valuable work. You know, Lakeland mentioned earlier about that $234 billion of in-kind care that's provided by informal caregivers. We also know that about $290 billion a year are paid for in the U.S. every year for paid care. So if you think about putting those two numbers together, we're over $500 billion today. But we know of that $290 billion of paid care, about 68% of that is in the Medicare and the Medicaid program. And that's where those rates are set to pay those folks. And we know that the budgetary issues that we have going on with that the compensation piece is always going to continue to be an issue that we have to continue to work on. We also know that staff should work in a supportive environment where their contributions combined really do contribute to the overall quality. So improving the working environments will also result in reduced turnover. Also, employees should have an opportunity for career growth, and recognize employee for job well done is something that just doesn't happen enough and can really help with turnover. And finally, staff should work with families in all settings to really help them understand that this is a partnership. So the next area is supportive and therapeutic environments. So supportive environments, both in long-term care and community settings, are really important. So the environment should support building relationships. And we know that comfort and dignity are the core of person-centered care. So comfort is about how a person feels, but dignity is more about how they're treated. And another essential element of person-centered care is respect for others and their environmental correlations as well. Settings should be pleasant with visual and physical access to engaging and safe outdoor settings, and supporting privacy and security of their personal space. So it's really about balancing safety and autonomy. And it's about opportunities for meaningful engagement both in the residential and home setting and in the broader community as well. So spaces should allow for individual activities and group activities. And while the environment is the backdrop and where real life takes place, caregivers and care partners must be trained and understand how simple things like turning on a light in the middle of the night, or simply closing a curtain to reduce glare, or reducing unnecessary background noise can make a tremendous difference in the quality of life for someone living with dementia. So a couple of examples of how these could look like in everyday practice We now have some evidence around, for instance, toileting. So instead of having a closed door to the bathroom, and in the bathroom you have a white toilet on a beige wall, instead always make sure the bathroom door is open and paint the wall behind the toilet in a contrasting color. And as I mentioned earlier, the balance here is around safety and autonomy. So having a safe place for individuals to walk about inside and outside with a secured perimeter can greatly increase quality of life. We know that about 60% of people in the middle stages of Alzheimer's will have wandering behaviors. But instead of thinking about this in negative terms, walking about can have great benefits for mobility and exercise and strength training versus someone just sitting in a chair where there's a higher likelihood of them developing a pressure ulcer, for instance. But with increased mobility, there is a greater chance for falls, so having an environment that supports safe walking is important, as well as having sufficient and appropriate lighting in all parts of the community. So the final topic area is around transitions. And transitions in care for persons living with dementia includes movement across settings and between providers. And we know that there's an increased risk of fragmented care and then poor outcomes, like hospital-acquired complications, morbidity, mortality, and excess healthcare expenditures. So transitions in care are often unnecessary, unplanned, and stressful, and not just for the person living with dementia, but for the family as well. So preparing and educating persons living with dementia and their care partners about transitions in care should occur before, during, and after transitions. And while we know that transitions in care are probably going to be necessary for a great amount of people, it's essential to have that safe handoff. And after any hospitalization or significant change requiring a transition in care or care level of care, there should be a review and a reassessment of the preferences and the goals of the person living with dementia. So every member of the care plan team must be accountable and responsive to ensure the timely and appropriate transfer and the responsibility to the next level or care setting. And clinicians from the sending site of care should maintain responsibility for individuals until the caregivers at the receiving site assume that clinical responsibility. And the supplement has now several evidence-based models of care that are focused on avoiding unnecessary transitions or delaying or supporting placement in residential care settings. And targeting avoidable hospitalizations or rehospitalizations for persons living with dementia has the potential to reduce those poor outcomes most common with this population, such as risk of delirium or with falls. So we know common transitions can occur in many different settings, as the person living with dementia and their caregivers are the only common factor across levels and sites of care. A person-centered model to transitional care is viewed as a best practice to prevent adverse events and to improve care quality. So a person-centered care approach considers the needs, goals, preferences, culture, traditions, family situations, and values the person with dementia while integrating the family caregiver as the essential partner and whose needs and preferences are also considered. Also, one of the things that we did when we released the Dementia Care Practice Recommendations is we also polled our group called an Early Stage Advisory Group. And this is a group of individuals that work with the association every year. And we asked them when we released these recommendations to get their perspectives on what they thought good care would look like. And it'll take me just a minute to bring all these up. But I think you can see the similarities. So people with dementia are saying, and early detection and diagnosis is important. It's important to share that appropriate information and knowledge. It's important that we get to know them as a person and that we maximize their independence while we practice patience and compassion. And again, you personalize those cares to meet the individual's needs and preferences. And you adjust care approaches to reflect the day-to-day needs and abilities. And you provide ongoing opportunities for engagement that have meaning and purpose. And you train staff on the most current disease information and the most current strategies. And finally, you just create a supportive environment that reflects the person's characteristics, their personality, and their preferences. So what do providers do at this point, and how do they put all of this together? And it really is following something that we call a BPS, a Plan, Do, Study, Act cycle, a PDSA cycle. So they really start with developing a plan that outlines what they want to accomplish. And then they create short and long-term goals. And it's about making sure that the staff, again, from all areas are involved in this, not just the leadership. And it's about taking small steps. You know, a lot of times quality improvement projects fail because they start to accomplish too much. So let's say, for example, if an organization set a goal of moving staff towards consistent assignment, it should start small and maybe just one section of a nursing home or an assisted living community. And then when you encounter difficulties or roadblocks, you stop and evaluate and get help. And then it's very important, as I talked about earlier, to recognize and celebrate accomplishments, not only for individual staffs, but teams as well. And then you build on those accomplishments, and then you start the process all over again. So quality improvement work never ends, but it is an ongoing process that must be embedded in the culture as a norm for it to be successful. So Lakeland, from there, I'll turn it back over to you.
Thank you so much, Doug. That was all great information that you shared. And I'm just going to go back one slide because I like this slide. I'm going to leave it up here for just a second because I did want to point out that website at the bottom where people can go to get those documents you were talking about, the dementia care practice recommendations that came out in the Gerontologist. You can find that article on this website, alz.org/qualitycare. And also, if you wanted to read more on the perspective of individuals living with dementia, I think that is such an important component, getting a firsthand account from people living with dementia and what is important to them. And then when we look at this putting it all together slide, I know as professionals in the places we work, we can take this information back and use it to improve the quality care we're providing to the individuals living with dementia that we work with every day. But I think also family caregivers can kind of look at this as well. They can kind of develop a plan and work with their loved one or the individual living with dementia that they're caring for to create, some short and long-term goals and find that support system to get help, learning that, it can be some small steps that they can take to make improvements in the way they provide care and support to their loved one, and then celebrate those times when, the new strategy that I tried, that person-centered care approach, really worked well. Maybe it's in creating those meaningful opportunities to engage the individual in something that they enjoy doing, or perhaps it's helping them be a little more independent in their activities of daily living. So I think that this can also apply to family caregivers as well. So again, want to thank Doug for sharing that, sharing those recommendations and going into such great detail. I learned some new things, and I've heard Doug present this a couple times already. So thanks again to Doug for that. I did want to share some other resources before we turn it over to the Q&A portion. Of course, the Alzheimer's Association's information is on here. They have a great website, alz.org. A lot of people don't know that they have a 24/7 hotline that is staffed by professional social workers. Is that right, Doug? I don't want to speak out of turn on that. Could you talk about that helpline just for a moment?
Sure, and thank you for bringing that up, Lakeland. Yes, really encourage people at any point to call our 24/7 helpline at 1-800-272-3900. 24 hours a day, 7 days a week, 365 days a year. It's manned by master-level clinicians that are there to help you. And it's a tremendous resource. So we really encourage you to call.
Thank you so much, Doug. I've talked with family caregivers who have called this helpline, and they found it to be very helpful. It's in the name. But even, at 2 a.m., if a caregiver is really frustrated, or if that's the only time that their loved one is sleeping and that they have to reach out for care and support, again, that hotline is available 24/7. So great resources there. The Alzheimer's Society of Canada is also listed up there. And we talked about how dementia is kind of an umbrella term, and Alzheimer's is the most common. There are resources out there for those other types of dementias, and a lot of people also don't know about these associations. So the Association for Frontotemporal Degeneration is one that is a great resource. They have a hotline, as well as the Lewy Body Dementia Association. They also have a hotline, so you can visit those websites for more information on those specific types of dementia. The Alzheimer's Association also has great resources on, again, the science behind the disease, the latest research, that prevention. I know Doug had mentioned that that's one of the goals or one of the key focus areas of the Alzheimer's Association. And many family caregivers are very concerned about developing Alzheimer's disease because their loved one has it. So great information out there on prevention and risk reduction. And then Home Instead Senior Care, we have some great resources for family caregivers. helpforalzheimersfamilies.com. There's a free online education series on there. I host monthly live chats with guest experts on various subjects related to Alzheimer's and dementia care. And then we also have a dementia respite care grant program in conjunction with Hilarity for Charity, of which you can apply for on that website for those who might not be able to afford respite care. We also have a great community on our Facebook page, Remember for Alzheimer's. I hope you will go out there and like us. We have a great conversation on there, a lot of caregivers sharing their stories, sharing support tips with one another. And then we have some great general caregiving resources on caregiverstress.com. So again, I want to thank you so much for tuning in with us today to learn about caring for someone with dementia and that person-centered care approach. Again, research is showing that when we take a person-centered care approach, the outcomes are more successful. So really getting to know the individual living with the disease, tailoring our care and support to meet them where they're at, whether it's in the disease process in general or just day to day, and then also creating opportunities for them to engage in a meaningful way. Maybe it's through supporting them through their activities of daily living, whether it's, looking back in their history to figure out, what were some of their passions, the activities they enjoyed, and then creating those meaningful opportunities for engagement. And then, of course, plugging into all of these great resources is another great way for family caregivers to get the support to help them continue to provide that really important care to their loved ones living with dementia or Alzheimer's disease. So with that, Steve, I'll turn it over to you because I know we have some questions coming in. So Doug and I will be happy to answer those now.
Great. Thanks very much, Lakeland and Doug. Yes, everyone, it's time for the Q&A, so send in your questions right now. And let's jump right into it here, presenters. First question for you here. How do you best support caregivers that feel hopeless and burned out, knowing there is no cure, only a hopeful ease of symptoms?
That is a really good question. That I interact with caregivers. I'm sure Doug comes across this too from time to time where caregivers feel a sense of hopelessness and they feel overwhelmed by their caregiving situation. I think that's where it can be really, really important to get plugged into support and resources. I know that the Alzheimer's Association has support groups across the country. So, Doug, would you maybe want to speak to those support groups? And then if you have any other suggestions, I would welcome your thoughts on this question as well.
Sure. Yes. If you go to our website, it will direct you to how to find a support group that's close to you. And I totally agree with Lakeland. I think we find that people that engage in those support groups really do find a sense of comfort in sharing their stories and working with other people. And again, I think, we just want to say, if you're ever feeling at 2 a.m., as Lakeland said, hopeless and upset, that's the perfect opportunity to call our helpline. Don't ever feel like you're a bother. You're not a bother. We're the reason that you're here. We're here for you. And once you call our helpline, it creates a record. And so if you talk with one of our care consultants and you are having an issue, and then maybe a week later, there's another situation that arises, you don't have to start that whole process back over with them. They already know who you are, and they'll just pick right up those conversations back with you. So support groups are a great opportunity, but really utilize our helpline as well anytime and with any question. There's no question too small to ask.
Thank you so much, Doug. And I think I'll add just another quick thought to that. Sometimes when caregivers are feeling that sense of overwhelming, they're they're stressed out, burnt out, sometimes taking time away from the caregiving situation to refresh. We call that respite. Respite from the caregiving situation can really go a long way in helping to reduce that burnout, to reduce the stress levels. So whether that's having a family member, friend, or neighbor come over for a few hours so the caregiver can get out and about, maybe go to their own doctor's appointment, go for a walk, get their hair done, little moments that they can get away, or it could be hiring a professional service like the care that we provide here at Home Instead Senior Care. And it could also be a short-term respite stay at a care facility or checking out an adult day service or adult day center in your community where you could take your loved one for a portion of the day. Those are great options for respite care. And I know that the Alzheimer's Association has a community resource finder that is available online. Doug, I keep going back to you to tell us more about this, but I think it's such a great resource.
Sure.
Would you mind sharing a little bit about that resource as well?
Absolutely. So again, if you go to alc.org and there's a search bar and you put in Community Resource Finder, and then it will direct you to put in your zip code, and from there it will pull up all of the resources that are available in your zip code. And so it's a great resource to help you get started in finding the care that Lakeland is talking about.
Thanks, Doug. And thank you so much for that question. It is a common question.
Okay, thank you. Next question. How do you convince caregivers that family members require help when the person is able to perform ADLs and the family doesn't quite feel that they require help?
That is a good question. Sometimes it can be challenging for a family caregiver who's probably, it sounds like, the primary caregiver in this situation. So when we look at caregiving, there's often a primary caregiver and then secondary caregivers. So that primary caregiver is likely the one that's taking on the majority of the day-to-day care and support of their loved one living with dementia. And then the secondary caregivers might be other family members who support from time to time. And so I could definitely see where it can be frustrating for that primary caregiver when the secondary caregivers or other family members are wondering, why is care and support necessary? So, in this type of scenario, if it's in Sorry, I'm collecting my thoughts here because I want to approach this delicately because the situation is very different for every family. And without knowing more details on family dynamics and that sort of thing, it can be challenging to help families kind of navigate this situation. But sometimes what can be helpful is to kind of have a family meeting or a conversation about the individual with them present and having the individual part of that conversation. So recognizing the areas where they need some additional care and support, and then looking into the options for that care and support and prioritizing their needs. It is, again, a kind of Doug, you want to jump in here and add some additional thoughts?
But I think what you said is great. I think this is an area, too, where it's really important to have that diagnosis. If you have a loved one who's experiencing some of the symptoms that you showed earlier, Lakeland, then it's important to reach out to the physician and clinician and to get an accurate diagnosis. And if there is a diagnosis of dementia, then that's where it's really important to have that assessment and that care plan, and to really help understand the disease progression. And the goal is to keep people as independent as long as possible and for people to do their self-care as long as possible, and then to help them with adaptive processes as you move along the way. But I think having a diagnosis, having a good relationship with the physician, clinician, and then having them help you or going to places like our Community Resource Finder when you're getting to the point where you may think you need that help, and then developing a plan together.
Thank you so much for adding that, Doug. And I will say that slide that Doug shared earlier about those activities of daily living. I know you can download the slides or you can go out to that article in the Gerontologist to read through suggestions and tips for supporting someone in their activities of daily living. So there's lots of great resources out there, and sometimes it's a matter of just sitting down and doing a little searching, but hopefully those tips can be helpful to that family in that situation. So thank you for that question. And thanks, Doug, for your added suggestions.
All right. Well, Doug and Lakeland, unfortunately, we're out of time here for today's webinar, but I want to thank you for joining us for a great presentation on a very important topic. Thank you.
Thank you. Have a great day, everyone.
Much.